I'll take you through the pragmatic as well as a comprehensive evaluation for management of thrombotic microangiopathy. Now, we all should understand that when you use the term thrombotic microangiopathy, it doesn't only mean atypical HUS, it means TTP, typical HUS, which is the sugar toxin induced E. coli related HUS as well as atypical HUS. So when you say TMA, it is all three. Okay, it is TTP, atypical HUS as well as the typical sugar toxin induced HUS. Now, if you look at this pictogram, the previous speaker has already told you about the classification. I'll just take you through some pertinent points. Currently, it's classified as primary and secondary. Primary is again classified as hereditary and acquired. Okay, so hereditary are all the TMAs that have a genetic mutation. Now, these could be either TTP, which has an Adams 13 genetic defect. It could be atypical HUS, which will have complement related or non-complement related gene mutations, or it could be even congenital genetic mutations, for example, the cobalamin C deficiency, where you have a deficiency in the cobalamin synthesis gene. When you come to the acquired, it is when you say primary TMA, which is acquired, it means that there is presence of autoantibodies. So again here, it could be TTP, which has autoantibodies against Adams 13, or it could be atypical HUS, typically having autoantibodies against factor H. Again here, you should understand that this classification is not equivocal. It overlaps. So in a patient with atypical HUS who has factor H antibody, many of these patients have a predisposing genetic abnormality, mostly a CFHR 1 or 2, 3 deletions. So it is not a mutually exclusive classification. Now coming to the secondary HUS. The secondary HUS, again, there is a whole lot of infection-related HUS. Here we have the typical sugar toxin E. coli related HUS and the pneumococcal HUS, which have very distinct pathomechanisms. And these are not, so these are, they have a distinct pathophysiology. HIV related was more common during the pre-ART era. And there are other infections that can trigger a thrombotic microangiopathy. Now, the reasons are multifactorial. Again, here, you should understand that there are many infections that can trigger in people who have an underlying genetic predisposition. Okay, so they might well have a genetic variant here, and they may have a second hit as an infection, which will manifest the TMA. Now, coming to the secondary TMAs, there are many entities here. There are TMAs related to glomerular diseases. There are malignancy-associated TMAs. There are drug-induced TMAs. TMA secondary to autoimmune conditions, severe hypertension, and especially if you look at these two conditions, that is the pregnancy-associated TMA and the TMA after solid organ transplant. Okay, these are classified under secondary, but more and more evidence that a huge proportion of people who develop these two TMA have an underlying genetic abnormality. So just keep all these things in mind when you evaluate patients with all these triggering conditions. Okay. Now the defining feature of TMA are three: thrombocytopenia, microangiopathic hemolytic anemia, and organ injury. When you look at atypical HUS, it is kidney, which is the most common organ injury. But obviously in TTP, it is not the kidney, it is the brain, it's a neurology. The other ancillary test, the biochemical and the clinical test that will help you in establishing a diagnosis of TMA will be a raised LDH, a low haptoglobin, and a negative DCT. So once you have made a clinical diagnosis of TMA, the most common differential that we see may be a DIC, which is actually a problem of the coagulation cascade. But these initial biochemical tests can help you distinguish that. We also need to understand that just because you are saying it is atypical HUS, the manifestations are not limited to the kidney. Okay, people can have manifestations in neurological involvement, they can have cardiac, gastrointestinal, they can have digital gangrenes, they can have hepatitis. So just going by clinical scenario and distinguishing all these variants is difficult. So you need something more than clinical, right? This is just to tell you, now we will concentrate, the next set of slides will be on atypical HUS. And after that, I'll take you briefly through the other types of TME. In atypical HUS, we need to know that there are, these are abnormalities usually of the complement cascade. There are complement regulatory proteins, which can be either membrane bound or they can be in the circulation. As alluded to previously, especially in the case of factor H, if it is a C-terminal abnormality, it relates to a membrane-bound abnormality. That is, the C-terminal binds to the C3b that is present in the cell surface. And when it is in a solid phase, it leads to atypical HUS. And usually when it is an N-terminal abnormality in the fluid phase, the manifestation is usually a C3 glomerulonephritis. Another point that we also need to know when we assess patients are that factor H gene is in chromosome 1. And it is in the same chromosome that we find factor H related genes. And these are located just downstream of the factor H gene. And there's significant homology between these genes, which means that there can be various recombinations. And these can produce hybrid genes. These can produce large deletions or duplications. And it's quite commonly seen in these genes. Okay. Now coming to the genetic drivers of atypical HUS, it's been shown in literature that at least 60% of all atypical HUS cases have a genetic predisposition. But what do you mean by genetic predisposition? Generally, you say that there is a genetic abnormality only if you identify a pathogenic or a likely pathogenic variant. Okay, VUS is not classically, we don't say it causes. It might, with accumulating evidence in future, may get reclassified into pathogenic or likely pathogenic, but as of now, it will be based on whether the mutation is pathogenic or likely pathogenic. And most of them are complement mediated or non-complement mediated gene. In non-complement mediated gene, the ones that we need to look out for are thrombomodulin, the diacylglycerol gene, vitronectin, and recently there have been reports of INF2. INF2, as you all know, is a common cause of adult onset FSGS, right? It is not associated with TME, but there are certain SNPs in INF2 which have shown to cause TMA as a manifestation. And we recently had one reported from a case in Mumbai where the patient had transplant, had an immediate on the table, had a post-transplant TMA, lost the graft, they did a genetic mutation, and it was an INF2 gene mutation. Now, when we say a genetic abnormality, always remember it is not, we can't say it is causing. There has to be a separate trigger. In most of the cases, there'll be a second hit. So it is a two-hit hypothesis. Okay, you have a genetic predisposition and you have an acquired trigger. The acquired trigger can be either an infection or it could be pregnancy, drugs, post-transplantation. Now, the common endpoint for all these triggers are usually complement activation. Okay, as we know, in pregnancy, what happens? Normally, the complements are activated. If you look at the feto-maternal interface in the placenta, Normally complements are activated. This when this becomes out of control, it can become the second trigger. Even in infections, complements are activated, right? The innate immune system is activated in infections. And even in post-transplant scenarios, with CNIs and ischemia reperfusion, the complement cascade is activated. So what are the clinical dilemmas that we have now? One is the complement-mediated TMA can be mimicked by a host of secondary TMAs. There are multiple potential triggers. And if, depending on the etiology, the chance of recurrence post-transplant can be low, high, or moderate. And it also has implications for living-related donors. Hence, just a clinical classification or basic test may not be enough. And that is why now, in most cases, a comprehensive evaluation of the alternate pathway is recommended. Now, what do I mean by comprehensive evaluation? These could be 5 types. One is you measure the serum levels of different complements and complement regulators. Second is you look at the serum levels and quantify their activation products. Third are looking at acquired drivers, that is autoantibodies. So you have C3nef, you have C5nef, you have factor H antibody. Then also you have functional assays. Functional assays look at the activity of the alternate or the complement, classical complement pathway. And you have genetic analysis looking at the various genes. Now, so when do we consider genetic analysis in a case of atypical HUS? This is the criteria that's generally recommended, especially when you have more than one family member who have a diagnosis of HUS. There is an individual who relapses, the HUS relapses in an individual after complete recovery, or you do not have, you have a secondary cause, but not the classic Shiga toxin induced E. coli HUS, which can be like a secondary trigger, and there can be an underlying genetic basis. The diagnosis of genetic HUS is based on the presence of pathogenic variants. There are two ways of genetic inheritance. One is the heterozygous dominant inheritance of one of these complement or non-complement genes. There can also be homozygous recessive inheritance, and this is especially true for diacylglycerol as well as INF2 gene. One thing that we need to know is even if you have a gene, it doesn't mean that you will manifest the disease. Okay? Because you have to understand that most of these autosomal pathogenic variants have incomplete penetrance. That is, they don't manifest the disease 100%. And one of the important factors for manifesting the disease is age. So as your age increases, your penetrance increases. It has been shown that when you reach 70 years of age, the penetrance of these genetic mutation increases up to 65%. Apart from single nucleotide polymorphisms or single mutations, there are modifiers that can cause, that can be the predisposing factors. And these are related to groups of SNPs in genes like CFH or CD46, or there could be homozygous deletions of CFHR related genes. Now coming to the ways in which you can do genetic testing, they can be either single gene, which is usually not recommended, only if it is a very young child who has most probably a diacylglycerol autosomal recessive kind of inheritance. You have multi-gene panel. Again, here you should be careful. You need to include all the complement related and non-complement related genes that cause HUS. And you will have to specifically look for deletions in complement factor H related genes, as well as the haplotypes. Hence, the most comprehensive genetic test that we recommend will be whole exome sequencing, but you can have a virtual panel of complement gene to do an initial screen and then expand the panel if you don't find anything in the initial virtual panel. Also, you will have to do an MLPA, though you can get some indication on CFHR related CFHR 1 or 3 deletions. Those are large deletions in NGS panel. It depends a lot on what controls are being used and whether those controls are standardized. Hence, a second test like MLPA is essential to confirm CFHR 1 or 3 related, these gene related deletions, large deletions or duplications. Okay, this I have already alluded to previously, so I'll not go more in detail. So these are autosomal dominant pathogenic variants, and there can be autosomal recessive homozygous variants. Polygenic inheritance is when you have genetic variants in more than one complement related or non-complement related genes. So now what is the role of plasma infusion? Now, though we are in the era of eculizumab, we cannot underestimate the role of plasmapheresis, okay? Just because we are in a role of eculizumab doesn't mean that plasmapheresis does not have a role. And in most cases, at least in the current scenario, eculizumab is not affordable for many of our patients, and we have to rely on plasma exchange. So despite the variability of response, if the patient comes to emergency or your clinic with evidence of MAHA, thrombocytopenia, and organ injury, and you have diagnosed TMA, I don't think you will have enough time to go and get the drug eculizumab. The first line therapy for you at that point is to immediately institute plasma exchange after taking a blood sample. Now I'll come to that, what blood sample it is. Plasma exchange is usually the monitoring parameters are platelet count and serum LDH. Now, this genetic abnormality help you to optimize plex treatment. There are certain indicators that will help you and to prognosticate your patients as well as to understand whether it is going to overall improve your patient's care. So if it is CFH, there is definitely a role for plex because it replaces the CFH protein. Even in C3, there is a 57% response rate because the plasma exchange will take out the mutated hyperactive C3 and also provide the necessary regulatory plasma proteins. In CFB, there is very limited data for the use of plex. CD46 is a membrane, transmembrane protein, and theoretically there is no benefit. But there are studies which have shown that 80 to 90% of these mutations remit with plex. Hence, again, treatment will have to be tailored to your clinical severity. What about CFI? CFI, though it is a genetic mutation, and we would say that with plasma exchange, there will be replacement of CFI, the remission rates are quite low if you have a CFI mutation. It is mostly because CFI is a large protein, okay, and you need large volumes of plasma to correct this deficiency. In cases of non-complement related gene mutations, which are diacylglycerol, the benefit of plasmapheresis is not shown, even in INF2. Now coming to C5 eculizumab, which was approved by FDA in 2011. Again, it is useful, especially for complement gene related variants, but not for non-complement gene related variants. Some of the practical considerations for eculizumab therapy in your outpatient is meningococcal vaccine is mandatory. And though vaccine is mandatory, the serological conversion following vaccine is very variable. Hence, you also require long-term antibiotic prophylaxis. It is an intravenous infusion, and it is usually administered every 14 days. The monitoring parameters could be hematological indicators for TMA. It could also be CFH50 and AH15. At this point, I would like to say that Dr. Valentine's lab does many of these complement related tests, especially CH50, AH50, factor H level, anti-factor H antibodies, and C3. So some of them are done even in our center, but we don't do the activations. The other C5 antibody that has been recently approved by FDA is ravulizumab. The advantage of this over eculizumab is that it has a much higher, it's a longer acting. So you need to give it only every 8 weeks. Now, does the eculizumab have a role in preventing recurrence? Yes, both primary and secondary. Primary in people who have known pathogenic variants, and secondary in people who, to prevent post-transplant recurrence in people who had TMA-related end-stage kidney disease. Especially in secondary recurrences, there is a risk stratification from low, moderate, high. I'm not going too much into details of this because of the want of time. Other drugs that are being evaluated in different phases of clinical trial. Some of the promising ones are avacopan, there's iptacopan, there is anti-factor B drug, and cemdisiran. What about renal transplantation outcomes? Again, there is a role for genetic testing here to define graft prognosis, especially C3, CF5, and CFB, the graft failure rates are very high. MCP, there is no recurrence, and you can safely go ahead with renal transplant because it is a kidney-related protein. CFH, definitely combine it with a liver transplant. Diacylglycerol, again, there is no recurrence. You can safely go ahead with renal transplant. Thrombospondin is a very contentious thing, and it might require protection. Now, can we discontinue eculizumab in patients who have been started with us and who's had a recovery? Again, it has been shown that though eculizumab initially, when it was licensed for lifelong use, though there was no evidence. But now there is emerging evidence that you can safely discontinue eculizumab, at least in a proportion, a subset of patients. It is not advisable in those who harbor a CFH mutation. With experience in using eculizumab, it is also shown that some of them can have non-response to eculizumab, okay, just because they have a complement-related underlying abnormality. And you should also understand that all the studies that have been done using eculizumab, most of them have not had an underlying genetic abnormality. Okay, just because you don't have an underlying genetic abnormality does not rule out a complement-mediated HUS. Now, 27% of individuals without an identified complement abnormality failed to show an improvement. They've also shown that a polymorphism in C5 gene has been demonstrated to hinder the binding of eculizumab, and those who don't respond to eculizumab have been advised to undergo genetic screening for this polymorphism. Also, individuals with non-complement related genes can have non-response. Hence, there are various genetic dilemmas too, in addition to the clinical dilemmas. Now, just to go briefly through the other forms of TMA and how we will approach it in a pragmatic way. One is, first is to diagnose TMA based on the essential clinical and biochemical tests, okay, which is thrombocytopenia, MAHA, and the ancillary clinical tests. Now, once you have diagnosed and have ruled out others like DIC, then the first thing is to institute plasmapheresis after taking a blood sample for what? For Adams 30. Okay, so you institute plasmapheresis after plasma exchange after taking a blood sample for Adams 30 genome activity, and that is the first line. Every other evaluation will be after that. So after you institute plasmapheresis, you go ahead with a comprehensive evaluation. The results of all the comprehensive evaluation is going to take some time. It's not going to come immediately to you. So you meanwhile look at all the other secondary causes that can be ruled out. There are specific tests. For example, typical, you can have sugar toxin detection if there is sugar toxin suspected E. coli. Pneumococcus, again, if there is isolation, then it is supportive treatment. HIV, other infections can have complement gene abnormality as an underlying, as a predisposing factor. So you need to be careful. You may continue plasmapheresis till those results come. Drug-induced TMA is very interesting. Drug-induced TMA can be because of either autoantibodies or to platelet glycoprotein complexes, or it could be because of a dose-dependent toxicity, and this is true for many of the chemotherapy drugs. Or as in the case of ticlopidin, it could be an autoantibody to ADAMS13, right? And most of the cases, the treatment is immediate drug withdrawal, except for ticlopidin where there is a role for plasmapheresis. Then we also looked at other secondary causes, which is hypertension. Now, it's very difficult for you in a clinic to know whether it is hypertension which caused TMA or TMA which caused hypertension. Hence, may be safer. Usually, if it is a severe hypertension that causes TMA, then with the BP control, the parameters, that is a MAHA, platelets, all that should normalize. If it is not normalizing, and if it is proceeding to an end-stage kidney disease, definitely it requires, it will require a comprehensive evaluation. Then there are autoimmune diseases where the treatment is treat the underlying condition. You have bone marrow transplant related TMA. You have TMA post solid organ, that is post-renal transplant, for example. Here again, a high proportion of patients will have complement gene abnormality, and you will require a comprehensive evaluation. Malignancy, again, there's no role for plasma exchange, and DJK, again, there's no role. Now, these three entities remain, okay? The complement-mediated HUS, the post-renal transplant HUS, and pregnancy. Because there is a high proportion of patients who have complement abnormalities, mediated abnormalities, these could go in for flex and eculizumab. So the take-home message here is to establish the cause of TMA after complete evaluation. Acute decision-making is time critical, and the initial priority is consideration of plex. Urgent management is important because the high mortality, especially if it is TTP. And if ADAMS13 excludes TTP, then obviously there's a role for plex or eculizumab depending on the underlying condition. Thank you.